Today, we're focusing on a reality that millions of older adults are facing, living with multiple chronic health conditions. Chronic illnesses don't always happen one at a time. They can cluster together, and older adults may find themselves living with heart disease and diabetes, or arthritis with depression, stroke with cognitive changes, or all of that in combination. And suddenly the work of daily life revolves around medications, appointments, and physical limitations, and it can be very overwhelming, exhausting, and discouraging. So how do we age well when life feels medically complex? How do we protect our function and motivation and independence when our bodies are overwhelmed and asking for more support? And more importantly, how can we improve our health span even when illness feels like an uphill climb? This is Aging Forward, a podcast from Mayo Clinic about the science behind healthy aging and longevity. Each episode, we explore new ways to take care of our long-term health, the health of our loved ones, and our community, so we can all live longer and better. I'm Dr. Christina Chen, a geriatrician and internist at Mayo Clinic in Rochester, Minnesota. In this episode, we are joined by Dr. Brent Smith, a physician in the Mississippi Delta region and a board member and leader within the American Academy of Family Physicians. He brings deep experience in managing chronic conditions in real-world settings, not just one diagnosis at a time, but the day-to-day living experience and with the challenges that come with multimorbidity. Thanks for joining us, Dr. Smith.
Thank you. Thank you for having me.
To start, Dr. Smith, we'd love to hear more about your background, your role as a family medicine physician, and the community that you serve. Can you tell us more about that?
So I was born and raised in a little town called Cleveland, Mississippi. It's a town of about 12,000, 15,000 if the college is in session, roughly. The Mississippi Delta has drastically impacted my outlook on life as well as my professional career. Arguably the second most impoverished, under-resourced portion of the country behind certain regions of the Appalachians. It is an area that's really rife with chronic disease.
So I'd like to start by framing the problem of multimorbidity and just how it fits into the real-world context. We hear this term multimorbidity a lot, which sounds scary. You know, the term morbid, it carries a weight of hopelessness. And I just want to start by helping our listeners understand this better. Can you explain multimorbidity? We know that it's the existence of two or more chronic conditions at the same time, but why does this happen?
So I often have to delicately frame this conversation with, especially my older patients who wonder why we're having conversations about certain medical conditions and why it just can't all be fixed. And I tell them, you know, if you were an antique car, because you're more than 25 years old, so therefore you're an antique, you would expect to have some issues. You're going to have a belt that slips. You're going to have a tire that doesn't align as well as the other ones. You're going to have some holes in the seats. That's expected. Why don't we expect the same thing out of our health and our bodies as we do of the things we live and work with? And so by framing it as a sense of the longer we live, the more wear and tear on our bodies we're going to accrue, it helps people begin to understand that medical problems are going to accumulate the longer you live. It's nothing you're doing wrong. Our bodies are finite and they will eventually wear out. When you paint it in a picture that makes sense to people, I think that they understand better what it means to age. And what it means to age is that you have to spend more time, like you would with an antique car, taking care of the maintenance to keep your vehicle running.
I really like that analogy. I actually use it myself as well, that, you know, eventually things will break, but how do we fine-tune things, I guess, as early as possible so it doesn't break, can last longer. And when it does break, there are ways to fix it. It may not be perfect afterwards, but you can still use an antique car and you can use it very well.
And the great thing is that when you put it into a perspective of like, we all have that thing in our life that we put up with or treasure even with its flaws. It could be that piece of furniture you refuse to get rid of, even though it's scuffed and it doesn't fit with anything else in your house, but it's special to you. When we think of the mileage that you have, you earned, and what that means, and it can reframe that context of a life well lived and living with the body that you earned.
Right. So when people are living with multiple chronic conditions or living with a very, very rundown car, if we're using that analogy, what does life typically look like for that person? What is their day-to-day experience?
So hopefully it's approached with a proactive mindset. So if you are the type of person that wants to manage their conditions and be part of that decision making process, then yes, it can involve a lot of upfront work. You'll focus a lot on your patterns of life, making sure that you are making decisions based on what's best for you health wise. So, with your diet and with making sure that you get some basic amounts of exercise or physical mobility in, getting your medicines taken on time, making sure that you are looking after just your hygiene and your health. The problem as you age is those things take more time than they did when you were 20.
Mhm.
So it just takes longer to shower and get ready and going than it did back when you were younger. And so it can leave you feeling more overwhelmed with just managing the daily activities. You're just trying to get from waking up to going to bed and having accomplished everything.
Yeah. And even just taking medications, when someone's on, 4 time a day taking medications, you sort of have to revolve your life around, is it time for my next batch now? Or is it time to empty my bladder? So a lot of people can't even leave their homes because it's either meds or bladder or bowel and then repeat. So it can be very repetitive in that sense.
And you have those patients that are on a dozen to 2 dozen medicines sometimes, and
Yeah.
that quickly becomes a process of just trying to remember to take everything.
Right. In your practice, Dr. Smith, what combinations of chronic illnesses do you see the most, and why do they tend to cluster together?
So I live in a region that's well known for its propensity for diabetes, but it's
Yeah.
a reflection of a larger issue of cardiometabolic disease, high blood pressure, heart attack, stroke, diabetes. Those go together quite frequently. Number one, because of our racial and ethnic background, because of a higher African American population, and we have a higher propensity of hypertensive diabetics. And then, second,
Hmm.
despite the fact that we live in an agriculturally driven region, nobody eats soybeans all day long, nor do they eat rice straight out of the field. It's difficult to get the fresh fruits and vegetables and the non processed grains because it is a more socioeconomically challenged area. Unfortunately, affordable food, cheap food is not healthy food, especially not in this part of the country, contributing to an obesity epidemic and poor dietary choices. And then the other thing that goes along with those is a fair amount of chronic osteoarthritis. We are a primarily agriculturally driven economy,
Hmm.
and that is not like desk work. That is usually out in the field, working with heavy equipment. Injuries add up. But other than that, you're just on your feet all day. And so you tend to see people that have those two things together.
So I'm hearing diabetes, hypertension, advanced osteoarthritis, heart disease. And on the surface level, someone may think, well, each condition can just be treated separately, right? Diabetes, there's insulin; hypertension, you've got some meds for that. And, it seems simple enough. But when all that happens at once or
Oh, yeah.
together simultaneously, that makes things a lot more complex. So can you kind of describe why managing multiple chronic conditions can be so much more complex than just, single disease treatment?
So there's two big factors that to me really change the way you have to approach that. Because diabetes and hypertension are the two big primary starting drivers, can be silent diseases for several years or decades even. A lot of times you'll see people that they get diagnosed with 14 things at one time.
Yeah.
This is your 45 or 50-year-old who's in reasonably good health as far as he knows, who's never really had to go to the doctor, and he's just working, doing his job, and one day he has a heart attack. He lands in the hospital and finds out that he's actually diabetic. His blood pressure is terrible. He's got mild chronic kidney disease because of that blood pressure that's been terrible
Mhm.
for a decade. Oh, also, you're going to be on an antiplatelet and an anti-cholesterol medicine. And so all of a sudden you went from nothing to 6 or 7 things. And that can
Right.
be very discouraging, overwhelming, and hard for them. So we get a fair amount of that, but we get a fair amount that's just over years you add on piece by piece by piece. And so the challenge is number one, not letting it be overwhelming. And then number two, keeping it streamlined as much as possible because
Mhm.
as you develop comorbidities and you develop multimorbidities, you also develop an extensive medication list. And those are not always prescribed by the same person. And
Right.
it's also not always prescribed in the environment of looking at the bigger picture. And that's where the complication of specialists come into play, which they're great. They're wonderful. We have several wonderful cardiologists. However, for them, heart disease is a nail and they hammer it. not always remembering that that same patient with heart disease might have chronic kidney disease, they might have diabetes, and they might have other things that interact as well.
Yeah.
So that's where it becomes complicated, keeping just different perspectives separate so that we can treat the whole patient.
Yeah, and I think that's what leads to my next question. When you see so many different specialists, you've got like 10 different specialists who are all prescribing different things, and they're coming to family medicine later on and internal medicines to say, all right, what do I even do with all this? What do I do from here? These meds may have been on my medication list for, gosh, the past 15 years. When you see this situation, how do you even prioritize what to address first when there's too many quote unquote cooks in the kitchen? How do you prioritize what to manage?
I'm going to tell you a fact that is terrible to admit to as a physician, but when I have a patient with several medical problems, and we're talking 3 or 4,
Mhm.
it's almost better when they come to you after they've just stopped taking their medicines for a few months,
Mm,
'cause then you can start over and say, "Okay, now I know what you were on before, but
mhm,
because you've been off of it for a while, let's take this like a clean slate and let's put you on what the evidence says you should be on
mhm,
for these things in the minimum amount and the most efficient way we can do it." And that often is quite helpful to be able to do that. But the biggest issue is not always getting clear communication from other physicians or providers about what medicines are being changed and why they're being changed.
yeah, yeah. I think I'd be really nervous if a patient came to me and said, "I stopped everything." I was like, "Oh my gosh, how long have you stopped everything?" And please don't do that. First of all, number one, don't do that. That's a little dangerous. And if you do, then that is an incentive to say, all right, it sounds like you don't want to be on all this medications, which can then prompt the discussion about let's de-escalate, let's sort of debride some of the stuff that you don't need to be on.
Well, here's the part that I've had to learn over a decade, which is it's not always about what they want, it's
Mm-hmm.
about what they can afford, what they understand, what they can actually accomplish. And so a lot of times that not being on it is a good chance to say, okay, why don't you take that? Or why didn't you get that filled? And if you've established a relationship with them where they don't feel like they're going to be in trouble for not taking it, and they can tell you, yeah, it's because it cost me $50 and I don't have that every month to pay.
Mm-hmm.
Or this medicine makes it to where I can't be sexually active, or this one makes me pass out when I'm outside, or this one makes my stomach hurt. If it's
Mm-hmm.
metformin, this makes me go to the bathroom all the time and I can't go out to the doctor or anywhere in the community. Then you start having those real conversations, and that's important and that's helpful. But it does go back to that. It would almost seem terrifying to have patients do that, but
Mm-hmm.
in an area like this where there's such a healthcare shortage, you can get that patient because they stopped on their own. You can get that patient because their doctor retired or moved, or you get that patient because they just moved the area. But
Mm-hmm.
you still have to deal with that challenge. And that's one of the reasons that in my residency program, we tell our applicants if you can take care of patients here, you can take care of patients anywhere.
Yeah.
Never going to get sicker, less advantaged patients than you're going to deal with them with what we got.
Are there any other warning signs that someone may be overprescribed or experiencing an adverse drug effect?
Number one is if you have some type of effect of a medicine that is bad enough that it makes you not want to take it,
Mhm,
that at least should have a conversation with whoever is prescribing it with you and be honest with them about it and say, you know, this medicine makes me go to the bathroom all day and I can't go to the grocery store without going to the bathroom and I'm not going to do that. I, as a physician, would much rather you tell me the truth rather than feel frustrated every time because I feel like we're not making progress because it's actually because you're not taking your medicine because you didn't feel like you could tell me. But the other thing is be honest with your physician or your provider or whoever you're seeing about just how you feel.
yeah, right.
Is unfortunately symptoms of medication interactions, sedation, fatigue, swelling, cramping, issues with your gut or your urinary system often go hand in hand with aging symptoms. So,
Mhm,
too much medicine can make you constipated. Well, guess what? As you age, your GI tract slows down as well. Too much medicine can make you feel dizzy. Well, also, as you age, you tend to get dizzy if you stand up real quick anyway. And this is a real deal breaker with a lot of people when they come in and they say, I'm on my feet all day, my feet swell. And I just have to tell them, hey, you're not 25 anymore. So that tends to happen as you get older.
Hmm.
So just being aware that having those conversations and that it may not always have a medicine that fixes it,
Right.
but at least being aware that some things we can fix, some things we can't.
Do you have a way of starting that conversation with people? What are like questions that you may ask to just sort of trigger that conversation about deprescribing? I liked the earlier one that as you mentioned, just how are you feeling, right? Or are you ready to start reducing your medications? Just to gauge their interest and their readiness because that aligns with their goals of care. What is your strategy like?
So for me, it begins with that medication review, which we focus on a lot consistently in our practice of doing that at least once a year, if not more, of no matter what, bring your medicines in. We're going to lay them out on the table and you're going to need to tell me why you take this,
Hmm.
and if you're taking it and why you're taking it. Another thing that accomplishes is getting medicines out of their cabinet that don't need to be there anymore, which is just a patient safety issue. But oftentimes they look down at the table and go, I didn't realize I was taking this much. And then
Hmm.
you start talking about, all right, why do you take this medicine? When was it prescribed? And if they can't even remember,
Hmm.
that's often a good point to say, all right, well, let's try off of it and see. The other thing you have to be clear with them a lot about is I'm willing to go back and forth with you about
Hmm.
this. These are not final decisions. If I take this away and you call me in 2 weeks and say, look, I feel terrible since you took away my this. Okay, let's go back on it. You were on it before. It's not hurting anything.
Yeah.
Let's keep trying. Now, the harder conversations are about the controlled substances and things that are increasingly in prescribing guidelines that are discouraged. Your
Yeah.
benzodiazepines that we take for just anxiety all the time, your pain medicine that we may get too much, things like that. That's a different conversation. It's a harder conversation. But if you've established that trust with everything else, then usually it can be done
Sure.
productively.
And some other trade-offs to kind of talk about is, medications are a form of treatment, but also diagnostic testing, preventive screening, and even just aggressive treatments that may or may not be aligned with their goals. When families and patients struggle with the question of should we pursue this treatment or focus on comfort or function, knowing their complex health history, how do you help people navigate some of those trade-offs of what to do, how to do it, when to do it?
I really think when I first entered practice, most of the conversation said, you've got high blood pressure. This is what you need to be on. And their response oftentimes was, okay, you're the doctor. You know what you're talking about. Do it. Let's go for it.
Mhm.
And then it's your job to remind them of potential side effects and risk and weigh that out. Now, increasingly, since 2020, it's been a hard conversation with the vaccines.
Yeah.
What it has done is it's forced us to get comfortable with a patient and say, I recommend this. Here's why. Also understand where I'm coming from. I'm in the area of the country that during the peak of the worst phases of COVID, we led the nation in per capita deaths.
Mhm.
We led the nation in per capita use of monoclonals. We were dead last in the nation in vaccinations for COVID. What that told us was everybody's okay with saying no until their life's on the line.
Hmm.
And so if you begin the conversation with, I want to be clear and transparent with you about the risk and the need,
Mhm.
and I need to be able to explain it to you as to why we're doing it. And it's changed the way we have conversations about COVID vaccines now and all of our vaccines. I had that conversation with a lady today. She doesn't smoke. She hasn't smoked for quite a while, but if you go by the low dose T recommendations now, she needs the low dose CT.
Mhm.
She said, why? I said, well, I would like to once in your life, at least, screen you to make sure we're not missing a lung cancer. I hope it's negative.
Yeah.
If it's negative, you're 80 something. She was, I believe, 83. I told her, we won't do this again. If you don't want to do it again, we don't have to do this again. And she understood. She said, yeah, okay, absolutely. And that's kind of the honest conversations you have to have with them. And there's been a lot of times in the last 4 to 5 years, I've looked a patient in the eye and said, I would like you to do this because I think it's the right decision for you.
Mhm.
And I would sleep better if you did. And there's been a lot of times they've said yes, and it made me feel better and made them feel better.
Mhm. And I think that gives him a lot of comfort to know my doctor knows me well enough where he will tell me exactly what will be best for me and take that burden off my shoulders or my decision-making process, even if, I don't know 100% what the outcomes will be, but you know them well enough that this will add to some quality of life afterwards or help treat their health condition. When we're talking about aggressive treatments, high-risk surgeries, vascular surgeries, and as someone who perhaps is very frail, who's in their 90s with heart failure and COPD, it's like, gosh, is that the right thing to put you through high-risk vascular surgery or help focus more on comfort or function at this point?
I can give you a patient that I have that conversation with once a month. He is
Yeah.
probably in his mid 60s. He needs bilateral shoulder replacements.
Mm-hmm.
However, he has terrible AFib and he has severe COPD to the point that the last time he had a COPD flare, they intubated him and they did not think they were ever going to be able to extubate him. He spent several weeks in the hospital, including time in the ICU. And so he came to me because of his shoulders. And I told him the first meeting, I said, you need a shoulder replacement. But there's nobody on earth that's going to replace your shoulder because you can't survive the surgery. Fair? And he goes, I understand that. I don't want to do that again either. So then we have very honest conversations about this is the options we can go with. This is what we can do to help you stay active, be out there and be healthy. What do you think would work best for you? And I'm willing to try any of these in concert or piece by piece, as long as you're honest with me about how it's working for you. And man, that's fantastic. They have a really realistic expectation of what the best outcome they're going to get is. And at the same time, I'm not feeling like I'm not being honest with them about other things.
I hope we can share more of these stories for our listeners because, a goal of our podcast is to give people hope and empowerment that we can do well despite these situations. And living with chronic conditions can be very emotionally draining for patients and caregivers, can be so hard, and it can be filled with a lot of grief and depression and mood disorders. Every day can be a struggle. What are some ways that you help them through these day-to-day experiences?
So a lot of it comes down to encouraging several key things, staying physically active as much as possible.
Yeah.
And it means you don't have to go run a marathon if you walk around the house every day, or if you're staying up and you're staying mobile, and it doesn't take much. You don't have to be you 30 years ago. You just have to be you 15 to 20 minutes a day of getting up, moving around. So realistic goal setting. And then second is there are several treatments and things that the guidelines say, hey, we should be more aggressive about your cholesterol or
Mm-hmm.
more aggressive about keeping your blood pressure 10 points lower. But for them, if that cholesterol medicine makes their muscles hurt, or they're convinced it makes their muscles hurt, or if they're getting dizzy every time we get their blood pressure to goal, then not being at goal for that patient is actually healthier for them if
Mm-hmm.
they are happier, staying active and engaging with you for everything else. And that's been the biggest growth thing for me as a physician. When I first came into practice, you looked at every patient and said, are they where they're supposed to be for all these things we're told that they should be at? Is their blood pressure at goal? Are they on the right combination of medicines? Am I doing this exactly right? And
Mm-hmm.
then 15 years or 12, 13, 15 years in, however long I'm in, I look at it more of, is that patient as healthy as I can make them?
Mm-hmm.
And that's a
Yeah.
different conversation. And so that to me has been a big change of, you know, when you hit a certain age, you don't really need your statin anymore. All right.
Yeah.
If you hit a certain age and you don't want to take all of your blood sugar pills and your blood sugar's a little bit high and you're happy, okay, that's fair. 85-year-olds don't need perfect LDLs. They need to be moving around and
Mm-hmm. Mm-hmm.
engaging with their communities and seeing their families.
Yeah. Thanks for sharing that. And from my observation, I think just working with your provider on symptom management, because symptoms are such a burdensome problem every day. What is causing the most burden? Because if there's something we can do to relieve that burden, I mean, I can think of several cases where I've got patients with 10 health issues. All of them are kind of stable, but the one thing that bothers her is the knee is hurtful. It's got advanced arthritis and it's been bothering her for years. We got that knee replaced and she was able to live well. So it's like you can live with chronic disease, but what's causing that day-to-day limitation that's really impacting your quality of life, I think is something that we don't often think about is what is the symptom that's the most bothersome.
Another example I have with that one is a patient I saw this morning. She's 63. She is a widow now. Bowling is her social activity.
Mm,
She is very good. She's gone to some national events. She's in a league. It keeps her out and social. She has rotator cuff tendonitis in her bowling shoulder. So we deal with that a lot.
mhm.
And it's quite frequent. And she gets shots in there as much as I can get away with. And we take care of that. But I know for a fact if she stops bowling, mental health issues will be huge because she
Yeah.
lost her husband in COVID and
Mm,
she is still recovering from that. So for me, if her blood pressure is a little high that day, fine. Let's make her shoulder feel better so she can bowl.
right, right.
If she's having some anxiety about flying to an event somewhere, let's take care of the anxiety so that she can bowl because her biggest life health risk factor is losing her connection with the thing that keeps her active and keeps her engaged.
Do you have any other, they could be small, but perhaps high impact changes that can help people live well despite their living with chronic illnesses? What are some other high impact changes that you could think of?
So, realistic physical activity setting
Yeah.
expectations with your patients, especially with my older patients. And, the problem is that everybody wants to do a couch to 5K.
Mm,
Realistically, 20 minutes a day, 6 days a week, or 30 minutes a day, 5 days a week is way more lasting long term than that one goal that you might get discouraged about 2 or 3 weeks in. I don't need you to commit to 3 hours of exercise every day. I need you to commit
mhm,
to 30 minutes and be consistent with it. If they come in and they're overweight, we never talk about their weight goal. We
mhm.
talk about how much we can lose per month or per week because that goal at the end can be quite overwhelming. But just being consistent and going piece by piece can feel very rewarding and empowering for them.
Yeah.
Increasingly adopting our GLP-1s and our other new weight loss medications that we're using when safe and when possible to help lose weight and stay active. And then last for me is the importance of the basic social activities and fighting hard to maintain those.
Mm,
The two biggest ones are if you're religious, go into your religious services. And
mhm.
number two is go grocery shopping. Don't let somebody else go do your grocery shopping and don't have it delivered. Go walk around the grocery store. At some point, your grocery trips last more than 20 minutes. And that alone can just be a small thing. But the other side effect of that is you have to see people and talk
Mhm.
to them and maintain your social engagements at church or even just your social activity. If you commit to continuing that, you've got to get dressed,
Yeah.
you've got to get there, you've got to communicate with people. It's physically active, it's out in the community. And if you have issues, other people will point them out for you.
I love that. Small victories, explore opportunities, stay social. Last night, I was at my daughter's eighth grade choir concert. And when I went there, I saw this older couple make their way slowly into the auditorium. They were both in their walkers, and I can tell that they just planned the whole day around that event. The older woman, she had a beautiful hat on, she had her makeup done and nicely dressed, and you can tell that they were so excited to just attend their grandkids' choir concert. And I just found that to be like the highlight of the night. That's what I want to see. These older adults coming out, exploring the world, just enjoying the day, even though they may have had some hardship getting there that day. That's something they look forward to.
You talk about that with an activity of your child. My
Yeah.
mother is in her mid 70s. She's got COPD, she's got high blood pressure, she's got a bad hip, but she goes to as many of her grandson and granddaughter's sports events as she can.
Mhm.
And we encourage it no matter what
Yeah.
for her to go because it means she gets out, she goes and does things, she's out in public and she moves around. And we have to commit to that part for her to keep those other things active. My oldest brother, who's his children that have all of the activities, he has to communicate with her all the time about where and what. But the side benefit for us is she's out, she's active, she's engaged, she's being healthier, and that's really important for us. And so even when it's frustrating and things are not as smooth as they should be, for us, our standpoint of taking care of somebody else's health, that's a big deal for us as well. Keeping her
Mhm.
active.
Mhm. I love hearing that. Thank you. We do have one closing question for all of our speakers. And that is, what does aging forward mean to you? And how do you personally age well, Dr. Smith?
So, aging forward to me is accepting the reality that our bodies fatigue and wear, and that's not a bad thing. It's not unexpected, and it's also not preventable. And so, accepting that and being part of it, then your task is, as a person, deciding how you want that to go. How do you want to write that chapter of your life, and taking
Mm-hmm.
ownership of it and being part of it? For me, it's a commitment to the basics of stress management and physical activity. So, my job in the current role is way more emotionally stressful
Mm-hmm.
than clinical practice. So it requires a different balance to be able to manage that stress and fatigue. And as I've progressed through, I've learned there's days I go home and I don't talk to people for a while, or
Mm-hmm.
I go fly fishing, because fly fishing is a place where I don't have to talk to my cell phone and answer emails and think about grants and budgets and employment and all those things. And so, just in learning that about myself and knowing that I've got to make the time to do those things
Mm-hmm.
has been a big deal for my health and aging as I am. Because I'm not, I'm 42 years old. I'm not 30-year-old fresh out of med school me that could go all day and work long shifts and not feel the impact the next day. So it's a different, just learning yourself as well.
Well, Dr. Smith, what a pleasure to have this conversation with you today. I think one big takeaway from me is that I think every chapter of our lives, it's a different mixture of complexity with every chapter, and we just need to find ways to maintain that joy, purpose, and staying active. And in older age and with health issues, those efforts are still very achievable to maintain that independence and that quality of life. So thank you for reminding of that.
Thank you for having me.
So that's all for this episode. Hopefully you're feeling a little bit more informed, inspired, and empowered. If you have a topic suggestion for a future episode, you can leave us a voicemail at 507-538-6272, and we might even feature your voice on the show. For more Aging Forward episodes and resources, head to mayoclinic.org/agingforward. And if you found this show helpful, please subscribe and make sure to rate and review us on your podcast app. It really helps others find our show. Thanks for listening, and until next time, stay curious and stay active.
This podcast is for informational purposes only and should not be relied upon as medical or legal advice. Always consult with a qualified healthcare provider for any medical questions. The appearance of any guest does not imply an endorsement of them, their employer, or any entity they represent. The views and opinions are those of the speakers and do not necessarily reflect the views of Mayo Clinic. Reference to any product, service, or entity does not constitute an endorsement of or recommendation by Mayo Clinic.